Immediately after birth, the human body begins reversing 9 months of intense physiological adaptation in a matter of hours. This massive internal shift creates a high-stakes window where a nurse's ability to differentiate a normal recovery from a life-threatening emergency determines the patient's outcome. To manage this transition safely, you need more than a checklist. You need a mental model that prioritizes the most volatile physiological changes. We are going to break down the postpartum assessment into a clear, actionable framework. We will focus on the 3 pillars that define patient safety in the first 72 hours: hemorrhage prevention, the mechanics of fluid shifts, and the strict protocols of postpartum pharmacology. Mastering this framework is your frontline defense against maternal mortality. Let's look at the first priority. After the placenta is expelled, the uterus must undergo involution. The uterine muscles contract to compress the open blood vessels where the placenta was attached, physically sealing off potential bleeding sites. When palpating the abdomen, look for this difference. On the left, a firm, grapefruit-sized uterus indicates successful contraction. On the right, a boggy, soft uterus means active hemorrhage risk. If boggy, immediately apply a 2-handed fundal massage, forcing the muscle to contract and clamp down on internal vessels. We monitor internal healing through Lochia. For 3 days, it should be dark red rubra. Days 4 to 10, it lightens to pink serosa, and by day 10, white alba. Deviations are critical warnings. A pad saturated in under 60 minutes or a large clot indicate potential hemorrhage. You also have to interpret vital signs within the context of birth. For example, a temperature up to 100.4 degrees Fahrenheit in the first 24 hours is common. In most cases, this reflects the extreme physical exertion of labor and the resulting dehydration rather than an emerging infection. Similarly, lab results may show a slight drop in hemoglobin and hematocrit. This is often the result of hemodilution. As extracellular fluid moves into the vascular system, it temporarily thins the blood, making these levels appear lower than they actually are. Recognizing these expected patterns allows you to quickly identify when a patient's recovery has moved from a normal physiological shift into a clinical crisis. After delivery, the body begins a rapid process of diuresis and diaphoresis to shed the excess fluid volume of pregnancy. A patient may urinate up to 3,000 milliliters a day during this initial week. This anatomical view shows why fluid volume is dangerous. A rapidly filling bladder pushes the uterus upward and right. A displaced uterus cannot contract, leading to hidden bleeding. Ensure the patient voids within 6 hours of delivery. A post-void scan over 150 milliliters indicates functional obstruction. If your assessment finds a high, right-deviated boggy fundus, your first action is to assist the patient in emptying their bladder. If you attempt to massage a displaced fundus without emptying the bladder first, the uterus will simply remain uncontracted because the physical pressure from the bladder is still there. You must resolve the root cause to stop the risk of atony. During this period of fluid shift, you may also see a white blood cell count as high as 25,000. While alarming in other patients, in the postpartum period, it is a documented stress response to labor and not an immediate indicator of sepsis. Managing the bladder is a prerequisite for uterine safety. Keeping the bladder empty allows the uterus to remain in the midline and firmly contracted. Finally, we address the pharmacological protocol, a coordinated effort to manage pain, prevent secondary trauma, and ensure long-term immunity for both the mother and newborn. We prioritize stool softeners like docusate sodium. This prevents straining during bowel movements, which protects episiotomy sites and perineal lacerations from secondary trauma or dehiscence. Immunizations follow 2 paths. Tdap is an immediate postpartum action to provide the newborn passive immunity. However, live vaccines like rubella and varicella require stricter oversight. Never given during pregnancy, we administer them now, but the patient requires a mandatory 28-day contraception window to avoid fetal risk. We also confirm the patient's Rh status. If an Rh-negative mother has an Rh-positive infant, there is a high risk their blood has mixed, triggering an immune response against future pregnancies. To prevent this, Rh immune globulin must be administered within a strict 72-hour window following birth. Executing this protocol correctly ensures the physical recovery of the mother while providing a safety net for current and future children. This framework allows you to see past the noise of the postpartum period. You are looking for the evidence of healing while remaining vigilant for the physiological indicators of crisis. Remember the priorities. Massage the boggy midline fundus, empty the bladder for the deviated fundus, and strictly enforce the 28-day wait after live vaccines. Apply these rules to every clinical interaction. When you understand the why behind these assessments, you can prioritize care based on the patient's actual physiological needs. These are the clinical foundations of safe postpartum care. Trust your assessment, follow the physiology, and provide the